Welcome everyone who is joining. We'll give folks a few minutes to make their way here. Just keeping an eye on our numbers. All right, I'm going to get us started. Welcome, everyone. Very excited for this workshop. So I am Allison Hamilton. I am the PI of the UCLA Rapid, Rigorous, Relevant Implementation Science Hub, funded by NIMH. And I am joined today by several wonderful colleagues. This event is being co-hosted by our counterparts in San Diego at the San Diego CFAR Implementation Science Hub. We're both part of a network of hubs that are funded by NIMH to support the federal Ending the HIV Epidemic initiative. We are so excited to share with you this workshop about rollout, implementation, optimization in practice. We'll be talking through methodological considerations and case examples. We have leading experts in the field on this topic and could not be more pleased to have them with us today. So our objectives, and then I'll introduce our wonderful faculty for the session. First, we're going to just talk through the methodological issues, and we could not be in better hands than those of J.D. Smith to hear about this study design and how it differs from traditional stepped wedge and hybrid implementation effectiveness designs, and really think through some methodological considerations for these types of studies and identify contexts and questions where this design is best suited. And you're going to hear two really thorough and interesting examples by two teams of folks that will help kind of put all of the information that JD shares in context. Before I forget, if you have not attended one of our workshops or beachside chats or other events before, we do record these and we'll make them available on our YouTube channel, and UCSD will also make it available on their channel. So this will be available to you later. And now it is my great pleasure to introduce our featured faculty for today. So we're first going to be hearing from Dr. J.D. Smith, who is an associate professor in the Department of Population Health Sciences at the University of Utah. All of these folks could have much longer bios, but that's not why you're here. So I'm just doing quick ones. Then you're going to be hearing from the team of Doctors Borsika, Rabin, and Nicole Stadnick, who are both at UCSD, with Borsika being an associate professor in public health and Nicole being a associate professor in psychiatry. And then you're going to hear from the wonderful team of Drs. Sylvanna, Vargas, and Anna Lau. Dr. Vargas is an assistant professor in psychology at San Diego State, and Dr. Lau is a professor in psychology at UCLA. So I think I covered all the bases there. When anything that I missed that you need me to mention?
That was perfect. Thank you.
Okay, wonderful. So I am going to turn it over now to Dr. Smith, who is our very cherished and honored guest and a real expert in the field in all things implementation study design. So over to you, JD. Thank you so much.
Thanks, Allison, and thanks to both of the hubs for organizing and hosting this mini workshop today. I want to make sure I'm in the right mode. Are you all seeing the full thing?
We are. Thank you.
Fantastic. Okay. So the ROIO trial design can be viewed essentially as an adaptive implementation research design. And what I'm going to talk about today are all the basics. So kind of the introduction to what this design is, what are some of the key considerations. So some disclosures, I don't really have any conflicts of interest. I am the co-lead developer of this trial design with Hendrix Brown, but like most stuff I do, nobody's paying me to do it. Acknowledgements, I want to acknowledge Hendrix, who, like I mentioned, is the co-developer with me on this. In terms of funding, I do have NIH, AHRQ, et cetera. And then I wanted to acknowledge the funding. You'll hear from Drs. Rabin and Stadnick about their U01 a little bit later today, that I'm a consultant on that grant. And then also I am MPI of the Mental Health Earlier Alacrity Research Center that you'll also hear about today, which is another funded ROIO trial. I also want to just raise this to everyone's attention for folks who are interested in rollout designs more broadly. We have a series of papers that are kind of co-led by RASC, CDS, the Mental Health Earlier Center, and Utah's CTSI. We're a directed DNI core. One paper by Greg Simon et al. Was published in Implementation Science earlier this year, and we have another under review. And the third paper is the In Preparation ROIO paper that I'm currently working on. So just be on the lookout for those. So let's jump right in to defining features. This is of rollout designs, generally speaking, and then I'll talk more specifically about the kind of unique aspects of what makes it a ROIO, not just a standard rollout design. So in all rollout designs, units, typically this would be clinics, maybe it's clinicians, providers, et cetera, care teams, are assigned to when they are exposed to a different implementation strategy condition. And so you're randomized or non-randomized to timing rather than to what you actually receive, given that everyone will eventually receive it. Randomization does reduce bias in these types of designs, just like it does in any trial design. And one of the other key aspects of kind of how we have some degree of equipoise within rollout studies is that there is some benefit to going early. In the sequence, you get your strategy sooner and get that support to implement an evidence-based intervention or program. But there's also some potential benefit to going later in the sequence in that the study team could be better at the implementation strategy. It could be a little bit more efficient. And so there are benefits kind of across both of those. In most rollout designs, typically there is one or more crossover from one condition to another. The most common is from implementation as usual to introduce a new implementation strategy. And those become the crossover points for each of the different units through the rollout sequence. In most cases, but there are exceptions to this, all sites are eventually exposed to the strategy or to the intervention, which is part of the reason that these designs are often preferred by community partners, is that sites don't serve as a true no intervention control for the entirety of the project. So a little bit more about rollout designs. There are kind of three key things that we always talk about with any study design. It's selection, allocation, and then measurement. And so in terms of rollout design selection, typically these are cluster randomized trials where you have clusters of clinicians, clinical teams, or clinics, or locations of care. But it can be done with groups of participants, different health systems, county level randomization, country level randomization, just whatever's most appropriate to your study design. Homogeny within these different clusters really helps with balance between your clusters, as well as reducing sources of bias. But heterogeneity can be handled with randomization and also larger samples to be able to ensure that balance across the clusters. Allocation, as I already mentioned, you are allocated to the position in the rollout sequence. Randomization will reduce bias. And then the assessment, you measure the outcome for a period before, but there are exceptions, as well as after the crossover. And after the crossover typically is a period that's long enough to detect the effect. So some of these rollout trials can have very short intervention or implementation periods because you can see the effect very quickly. Other times they need to be longer for delayed effects. So what are some issues with kind of the traditional rollout design? And everyone is probably familiar, at least by name, with a stepped wedge. A stepped wedge is one very specific rollout design. But for the most part, all these rollout designs have some shared assumptions or some shared features. One is that all units get the same exposure. In this case, we're typically talking about the same implementation strategy. And this is important because in a stepped wedge or other rollout, we do this so that we can combine the data across all of our clusters and compare our post-implementation period with our control or pre-period, and that gives us maximal power. But the question is, especially in implementation research, is do they really, right? So as we actually move through these different clusters, are we actually having the exact same implementation strategy be deployed? And I already kind of mentioned that there are that benefit to going later And that benefit to going later often is shown or is discussed as being what's called a learning effect or potentially a sequence effect, meaning that your position in the sequence is related to the effect that you get. And often, you might hypothesize that, later in the sequence will have a bigger effect or maybe a more efficient effect, meaning they get to a criterion a little bit more quickly. But these are not necessarily good things in the traditional rollout design. It's especially not good when there has been significant adaptation to the strategy, because then combining the data, you're actually combining data across exposures that are not the same. And so being able to actually have accurate causal inference about what was related, what that effect was related to, becomes very difficult. So if things get better over time, is it a problem? Is it a good thing? I think for most of us in implementation science, we would think it's typically a good thing that we're getting better and we're learning about how our strategies are working. And we're benefiting communities and our implementation partners. However, from a pure clinical trialist statistical perspective, this actually can be a pretty significant problem. And so what we wanted to do with this ROIO design is actually create a robust and rigorous trial method where we don't just deal with, well, was there a learning effect as a post hoc statistical analysis, but we actually intentionally try to improve the implementation strategies over time, in which case we are violating several assumptions of typical rollouts. So what do you do in these typical studies if things don't go well in early clusters? Can you change the strategy? What do you change? And is that going to be appropriate? If you're in, I think, pure true clinical trial perspective, if you have a strategy that completely fails in the first cluster and needs to have drastic change, that first cluster might actually get thrown out of being part of the primary outcome analysis. In a ROIO, that's exactly what we would want to have happen, is that we want to have the opportunity to improve. So let's talk about what this looks like. So the ROIO design, the rollout implementation optimization, is really a way to test iterative improvements in implementation. And I use that term intentionally, and you'll see why. That the iterative improvement approach is central and critical to a ROIO, and also makes it differ from other study designs, not just other rollouts. So the actual research question that a ROIO can help us answer is, can we identify an optimal strategy through iterative improvements of an implementation strategy between units and clusters? I'll define what optimal means soon, but essentially the general question again here is, can we optimize? Can we do things to improve the performance, the cost effectiveness, the efficiency of an implementation strategy through multiple attempts? So optimization, which you can also think of as the tailoring feature of the ROIO design, is by design planful and prospective. It uses early quantitative and qualitative data from the prior cluster to inform tailoring for subsequent units or clusters in the rollout trial. And I'll show this in a picture here in a second. So some of the assumptions that we have to go into a ROIO with is that the first implementation strategy bundle or package will be effective. I can't stress this enough. You do not want to start with your hands tied behind your back, intentionally thinking, oh, well, I'll just make improvements and I can show that it's better over time. You actually want to go forward with, we think this strategy is going to work. We think it's going to be feasible. And then we're going to try to improve from there. There's a reason for that if we want to get into it, but I just want to put out that as the assumption. The bundle then needs to be tailored or can be tailored to improve performance. And the performance is really based on what type of research question and data you have available. Are you looking for purely maximizing effectiveness on achieving an implementation outcome? Are you looking at something that's effective and feasible, and maybe by design, maybe by extension, also sustainable? What is the cost effectiveness of the strategy as well? So you kind of have to a priori specify exactly what's the most important aspect of what is considered optimized, and what are we going to use for those performance metrics. A couple things that the ROIO is not. So the ROIO is not testing 3 or more predetermined strategy bundles, right? That is simply a 3-arm trial or a 4-arm trial or a factorial potentially. So if that's kind of what you're thinking is, I have 3 different ways of doing this, or I have 3 kind of strategy things that I already know I want to test, ROIO is not for you. Because again, you're starting with a multi-component bundle that you think is going to work, and you're going to tailor it from there in multiple attempts. So it's iterations on the original or the initial implementation strategy package. Arroyo is also not a fishing expedition. So this is not a excuse to basically say, well, I don't really know what's going to work. Let's throw a bunch of stuff at it. We'll see how it performs, and then we'll mess with it. Everything really needs to be very hypothesis driven, well supported in the decisions about what different components would be comprising an implementation strategy package, and obviously very well justified. I don't think a fishing expedition ROIO would ever get funded because you would not be able to convince reviewers that what you're testing initially is going to be effective. But I just want to make sure that folks don't get that impression. Okay, so some of the methodological challenges for ROIOs and things that you need to consider as you're designing this, it really starts with strategy selection. So in the ROIOs that I've been a part of, or at least the ones that I've led, we are typically doing strategy selection and defining that initial clusters implementation strategy bundle a priori and with our implementation partners. Again, it needs to be very well justified, both empirically, but also conceptually. And we have relied on the implementation research logic model to really make sure that the theory of change and the theory of action that we are proposing for our strategy bundles address significant barriers that have been identified, and also are conceptually tied to the implementation outcomes that we're trying to achieve. One other piece with that is that it's not only the ultimate implementation outcome you're trying to achieve, but the strategies also need to specify what kinds of proximal outcomes you might be affecting, or processes that you can track as part of your tailoring approach with the ROIO. So more on that here in a minute. The other thing that's really important about the strategy selection is you're not just defining, here's the 8 discrete strategies that I'm going to include in my strategy bundle for cluster 1, and then say, we're going to mess with that going forward. What we have always done is in collaboration with our partners is we have basically thrown out a bunch of strategies. We've then gone through a prioritization process to say, okay, these are the ones that are likely to be most effective, most feasible, and they also cover within the IRLM the majority of the primary barriers, and of course, has a very well justified theory of action. What that leaves is a set of already vetted implementation strategies that are part of an IRLM that are sitting in a parking lot. And that parking lot is sort of your first place to go for making tailoring and optimization decisions as you move through the clusters. And I can give an example of that as we go. But essentially, these are pre-vetted. You can plug them into the IRLM in a way that you understand how they're supposed to function, so that when you have data that says, well, we're not really affecting reach the way that we hoped, you can look at what mechanism is supposed to be activated by specific strategies that you've been using. Maybe that hasn't actually been happening, and you have the data that says, hey, we're not hitting that mechanism. Maybe you need to actually choose a different strategy from the parking lot that acts on that mechanism, or acts on a completely different mechanism because maybe you guessed wrong in the initial selection. So you want that pre-vetted list in the parking lot. How many clusters and steps? They're kind of the same thing, but essentially, the question really is, how many attempts do you need to improve? The duration of a ROIO typically means that within the context of a multi-year, 4 or 5 year R01 type application or type, grant, you're not going to be able to have 6 or 7 attempts, both by power and by timeline. It's just not possible. So you're really deciding on, do I have 3 clusters, which gives me 2 attempts, gives me my initial guess, and then 2 tries to make it better. If you have 4 clusters, you have 3 attempts. And if you have 5 clusters, you have 4 attempts. So you really need to decide, how good is this strategy from the outset? And do I need 2 attempts or 3 attempts or 4 attempts to try to really make it better? So maybe the complexity of the strategy, the existing evidence for that strategy, et cetera, will help decide how many of these you need. Right, and more evidence-based strategies may need fewer bites at the apple, given that the likelihood that it will work is higher. The actual rollout schedule itself, you want to ensure sufficient time between clusters for optimization process. This is very different from a typical stepped wedge or rollout, where you could conceivably start a cluster every month. In Arroyo, you wouldn't have had enough time for your strategies to start working on your tailoring variables and for you to collect data, process the data, get feedback, make adaptations or changes to the protocol, and then launch in your next cluster. So typically, we're looking at 6 to 9 months in between the rollouts. And that's another reason why these trials end up taking a little longer than others do, because you're just not launching very quickly in sequence. When you're actually identifying your tailoring metrics, you want to select those that are sensitive to change as well as actionable, right? So we want things that we're going to be able to see early on in that 6 to 9 month period to help us understand if the strategies are working. And then you want also metrics that actually are actionable, meaning they're informative of what changes need to be made. So that's where the IRLM can be very helpful too in identifying process and proximal variables that might be more likely to show up and are informative. You also need to adopt analysis methods that are rapid and informative of needed changes. So we use rapid qualitative analysis as well as some pretty quick quantitative assessments that typically come from the EMR and other data systems, so that there's not a lot of data processing and management that has to happen. You also want to identify a priori the thresholds and/or the process for making modification decisions as you're optimizing. So you want this to be protocolized, and you want it to be, and part of the reason you want to protocolize it is so that it's replicable and it's a transparent process, so that someone who reads and understands, why did you decide on this optimization or this optimal implementation strategy package? How did you arrive at it? What data was used? Whose perspective was involved in the process, et cetera. So let me give a couple of examples, and this is where I'll show a figure of what the ROIO actually looks like. So this is a case study that was in the 2023 DNI book, the Proctor, Kolditz, and Brownson book. So that's a multi-component strategy that we were going to test to support adherence to the clinical practice guidelines for pediatric hypertension diagnosis. So this is a very well-known issue, that there's underdiagnosis of pediatric hypertension and elevated blood pressure. My own work, as well as the work of several others, has shown that this is the case across the United States and even in other countries. There is a clinical practice guideline that was published in 2017 for pediatric hypertension that has been shown to lead to better diagnostic accuracy when followed. But often it's not followed because it's very complex, as you'll see here in a second. So the primary aim of this was to optimize a multi-component implementation strategy package to improve identification of children with hypertension or pre-hypertension in safety net health centers. So the measures that we were going to be using to inform our optimization process was EHR data, so repeat blood pressure measurements, diagnostic rates, and some other things that are part of the actual guidelines that we can get quick and dirty information from the EHR to understand if that's happening per the guideline. We also did rapid qual with staff focus groups, interviews with blood pressure champions that were identified for each of the practices, and then interviews with some of the practicing physicians about what was working well and what was not. So here's what the ROIO actually ends up looking like in the schematic. So this design for this study was to do 4 clusters, so three bites at the apple in terms of optimization. Each cluster had 6 clinics, so 24 total clinics. You can see that there was a 12-month period of implementation preparation that happened with each of these. All the data to the left of these gray boxes is essentially our control data. So this is their usual practice and how they're identifying kids with hypertension. We would work with the practice for a year to all the implementation preparation stuff, including training, EMR function changes, et cetera, that were part of the strategy that we were using. And then we start to implement. So this is the crossover point for cluster 1. Here's the crossover for 2, et cetera. And what this is supposed to indicate is that these 2 gray quarters are the data that we're using to optimize the strategy as we move further down in the rollout sequence. So what we mean by that is you basically are going to have 4 to 5 months of data from cluster 1 to inform the changes that you make to your protocol right before you launch in cluster 2. And similarly, you'll do that process again from cluster 2 to cluster 3 and cluster 3 to cluster 4. What this doesn't really show very accurately is that when you get to cluster 3, you're actually using all available prior data from the 2 clusters that have been completed. And then as you go to cluster 4, you're actually using data from all 3 clusters. Because this approach is iterative, though, the process really relies heavily on the most immediate prior cluster, the N-1 cluster, not the other 2, because you're further away. You've made multiple iterations and changes since that initial cluster. So the data from cluster 1 is less relevant to making optimization decisions and tailoring for cluster 4, but nonetheless, it may still be informative, particularly about the longer term feasibility and potentially cost of some of the strategies, which may be a decision point for why you would change the strategy. So what this ends up looking like is that you have cluster 1, you have iterated on cluster 1, you have iterated on cluster 2, iterated on cluster 3. So you have 4 not independent, but also not the same implementation strategy. So you can't combine this data in the same way that you do a stepped wedge design. You really have to treat each cluster as a serial dependent cluster. Let me go through the next slide here. So what does package optimization or bundle optimization look like? We described this process both for strategy selection and then how we were going to optimize in this paper in Implementation Science Communications in 2022 by Ashley Knapp and Allison Carroll. We had a bundle comprised of multiple discrete strategies identified and prioritized as being feasible and likely effective by our implementation partners. We used an adaptive Delphi process that was based on the expert recommendations for implementing change study or ERIC study. And as I mentioned, we were heavily reliant on the implementation research logic model. Some of the things that we were going to do, training, some workflow changes, health information technology or EHR features and modifications to existing features, task shifting, et cetera. So a multiple component package so that it was easy for us to play with the different pieces of it. So when you're actually going to start doing the tailoring and optimizing, what can you do? So you can add new discrete strategies to your implementation strategy bundle, right? You can say that, well, we're not really doing a great job with adoption. It's because folks are not feeling that they have the right skills to do this, and so maybe we add a strategy that's really a skills-based training, and that's intended to augment and supplement the other training that's happening and really hit that adoption function there. You can also remove ineffective or infeasible strategies. So let's say of like 7 or 8 strategies, we realize that actually doing task shifting and having a nurse do this approach is not possible. It didn't really work. It's not really feasible to keep doing. Let's change that and go back to a physician assistant or somebody else doing that role. So things like that, you can just remove those ineffective strategies. You can also change the intensity, dose, frequency of the individual strategies within the package. So perhaps it was actually not that the strategy was wrong, but just the amount of strategy action that has to happen was not sufficient to move the needle. And so you might actually just not replace or change the strategy, but just do it slightly differently to try to increase the likelihood of its effect. How do you actually analyze a ROIO trial? So in this example, the primary outcome was the rate of accurate hypertension diagnosis. So we're looking at percentages every month that we can plot. So the analysis that we proposed here was 2 that answer slightly different research questions. So one was a time to criterion analysis over an 18-month implementation period. If you remember from the figure, there was 18 months of implementation for each of the 4 clusters. And what this analysis does is simply compares the initial cluster to the later clusters on their overall performance and time to reaching an initial criteria of 25% and 45%. So the question you can answer here is really, did we improve upon the first cluster? So not a terribly interesting research question, but a relevant one for this type of design. Analysis B, the improvement over time between clusters, is really the more interesting one. So this is really asking of, with the iteration and optimizations that we made between clusters, is there evidence that each of those changes had significant improvements over each other, right? So the significant differences between the 4 different clusters. And it may be that some clusters don't differ from each other, but that's the informative piece, and that can help you understand, obviously, whether the changes you made actually were useful. So to do that, we use a multi-level trajectory analysis. This is the plotting of essentially the time to criterion and the comparison of the initial cluster versus the later clusters, which combines those 3 clusters into a single trajectory. And this was the kind of the model that we used. We were powered, but power doesn't really matter in this context. So the other part that's really important for determining which strategy package is quote unquote the optimal one or optimized is cost. And so it's not just necessarily what is the highest effect that you can achieve and which of those clusters achieve the highest effect, which is the research question we can answer from those prior analyses on the last slide. But we also want to know, were the changes that we made and the strategies that we're using actually cost effective, right? So to do this, we're using incremental cost effectiveness ratios, or ICERs, which essentially means we're taking the cost of the strategy from cluster 2 minus the cost of the strategy from cluster 1, divided by the same effectiveness ratio, and determining whether or not that cluster was better, essentially cost effectively. Because we don't want to punish a smaller or larger cluster or have that influence, we normalize essentially the metric so that cost of implementation is done per 100 children, or you could do per clinic or something like that. But essentially, we wanted to have this on the same metric and not penalize if there was a difference in the cluster size. And then the effectiveness, was the percentage improvement in diagnosis here. So between the 2 analyses of saying, okay, which of these implementation clusters was the best in terms of achieving the greatest effect, coupled with which of the clusters was the most cost effective, will help you decide which is the optimal package. In a situation where you have 3 attempts or 4 clusters, like you had in this example, it may actually be the case that you may have a really good guess, and your first cluster actually works quite well. You make an iterative improvement; it seems to have worked well there too, and improved the effectiveness. And then you've made one more change, maybe using a more expensive strategy that does bump the effect, but not significantly, especially when you start thinking about cost effectiveness, in which case you might be thinking, oh, well, that means strategy 2 is our most cost effective, and it really wasn't worth actually doing that. What you could then do, especially if you have a very highly effective cluster 2 or cluster 3, is you can start to dismantle. You can start to actually take away the more expensive or burdensome strategies and see if you can maintain the effect. I think there are circumstances where you could potentially propose that we know this multi-component implementation strategy is going to work, but it's really expensive. And so the entire approach is actually dismantling, where you're taking away things with each successive step until you take away too much and it doesn't actually work anymore. That's another way to conceptualize the way of doing optimization. But again, that would be more in line with what's the research question and evidence base that you're drawing upon. In most situations, you're going to try kind of the more traditional or the more typical approach that I described first, which is take your best guess, try to improve it, potentially take away a little bit to see if you can keep the effect at a lower cost or higher feasibility. But that dismantling approach could potentially work as well. Sorry, let me go quick back through this. Okay, I'm going to show one extension of the ROIO. This is the study design for the Mental Health Earlier Alacrity Research Center that I co-lead with Lori Wachschlag at Northwestern. This is funded by NIMH. This is what's called a ROIO split plot design. So if this wasn't complicated enough, I'm going to add some more complication. What a split plot design is essentially adding additional components with a sequential approach. So you can think about this a little bit like a factorial design, and I'll show it on the next slide what that actually looks like. But essentially, we have a cluster randomized factorial or cluster randomized ROIO, where we have one trial that is starting in the green sections here, the dark greens, where we'll have 9 months of data collection, optimization, and protocol change, but only 2 attempts. at a certain point, so after this is, I can't remember exactly, it's 18 months or 21 months of implementation, we are adding then in additional implementation strategies. So Team for Equity, it's not called Team for Access. They are going to be introducing their strategy at this crossover point. So there's two different crossovers in the ROIO split plot. Simultaneously, another project within the center called Project Spark is implementing their implementation strategy, which is actually more of an adjunctive intervention with individual family level randomization. And what this allows us to do is test or answer a couple of different research questions. So as I mentioned, this is a two-phase factorial design where we're starting with PedsBright, the main implementation trial. We are then adding on Team for Access and Project Spark, which are a telementoring strategy as well as a growth mindset single session intervention. And these are compared to control within this design. And what that can help us answer is several questions. So the first question, which is just the bread and butter of ROIO, is can we improve implementation of the PedsBright trial, which is a family level intervention with clinic level randomization? The other questions we can ask are, can we improve the implementation of Team for Access and Spark? So that is the second half of this thing here, where we have two optimizations for Project Spark and for Team for Access as well. We also can then say, what is the optimal strategy for all three when they are implemented simultaneously or in the different combinations, because we'll have clinics that have PedsBright and Echo or PedsBright plus not, as well as families that get PedsBright plus the growth mindset SSI or not. We also can ask the question of, is PedsBright effective in improving toddler and family outcomes? So this is an effectiveness question. And then the other effectiveness questions are, does Team for Access and or Project Spark improve family engagement in PedsBright, which is really the function of what they're trying to do. And so we have both main and interaction effects. We can test the main effect of Spark and Team for Access and whether that works. We can also test it in its combination. So does a family that receives services from a clinician at a clinic that participated in the Echo telementoring program and also receive the SSI do better than a family that did not get either of those things or only got one or the other, right? So a host of additional research questions that you can ask and answer from a ROIO split plot, but you're probably already guessing this is a both very complicated trial as well as expensive. It's a $12.5 million center. Sorry, somehow I stopped sharing, so let me get back to that. Okay, let me go ahead and finish up. I want to leave as much time as we can for questions and for the other presenters. So some of the issues and future directions about ROIO is really a need to provide guidance on how to tailor variable selection. Oh, am I not sharing? Oh, I'm screen share. Okay. We also need to identify processes for optimization decisions. Who is involved in this? Which implementers? Which members of the research team? Are there other stakeholders and interested parties that should have some say in what optimization happens? And also how? Right? So how does this process go down? What is the decision-making process? How is data integrated? How is data processed? All those different things. And you'll see some examples from these other two projects that have already tried this in the real world. And as you're also probably already aware or anticipating, strategy tracking is really critical for a ROIO design, because you really have to demonstrate exactly what was done and then what changes, adaptations, modifications were made in between each cluster, and have that well documented, so that when you're actually saying this is the most optimal one, you have a very good description. But also when you're trying to understand why there are different effects or why improvements actually occurred or were seen in the data between clusters, you can go back to the implementation strategies and hopefully attribute some of those changes to the actual differences in the bundle or differences in the way that strategies were done in their dose, their action, et cetera. There also is work to do on additional analysis methods as well as other considerations. One of the biggest challenges of this, as I've already kind of alluded to, is that these are non-independent clusters, but they're also not the same clusters. So you can't combine the data in the same way that you do a typical stepped wedge or other rollout, but you also cannot treat them as three independent or four independent clusters because they are iterations upon one another. So dealing with that serial dependence in the sequence is critical in any analytic model. There's a lot more we could talk about, but I would like to turn it over to the next presenter so we can see this in action. And I will try to answer some of the questions in the chat as well as I'm listening to other folks.
Wonderful. Thank you so much, Sadie. Let me go ahead and share our screen, my screen here. 1 second. Oh, and of course it's not working as we practiced before. Could I request help from one of our co-hosts? Let me see. For some reason, I'm not able to find.
It looks like, Nicole, now you are a co-host, so let's try again.
So it won't let me.
Still no?
Yes. So
Let's see if I
unfortunately,
can figure it
Hang on
out.
tight. We'll pull up the screen.
okay, thank you so much. I apologize about that. I can set the scene as we get our slides ready for you. Borsika and I have been embarking on a really fun journey through using the ROIO design on a project called Co-Create X. This is a project that has built from some prior work related to increasing access to COVID-19 testing and other preventive healthcare services. Oh, thank you so much. Is Borsika, are you sharing? Okay, I really appreciate it. Thank you so much. Um, so well, I can if you can go to the next slide, Borsika. We want to acknowledge our funders. So this project is primarily funded by UO1 from NIMHD. And the other PI who's not on the call with us is Dr. Louise Laurent, who's also been on this ROIO journey with us. We also want to acknowledge funding from our P30 from our San Diego Center for AIDS Research, which is where our implementation science hub is housed. Okay, next slide, please. So the project that we're going to be talking about today as a case example is Co-Create X. This is a snapshot from or screenshot from our protocol paper in implementation science. It stands for Community Engaged Optimization of COVID-19 Rapid Evaluation and Testing Experiences. So this is a project that built on a few years of work that we did prior to this that focused solely on a no-cost walk-up testing site at a local federally qualified health center. We learned a lot from that first couple of years of the project and identified some additional optimization opportunities that led us into this UO1, which is our Co-Create X project. Okay, next slide, please. So just a bit of background. I think many of you are very familiar with some of this background. Thinking back about COVID, we saw health inequities abounding in particularly low income and ethnic minority communities. And throughout the pandemic, we saw persistently high rates of COVID in San Diego, particularly near the US-Mexico border. A really important and critical ingredient to addressing some of these inequities is and was meaningful community engagement. This was a really important component for us and for others in terms of implementation and sustained use of interventions that were designed to address inequities. So Co-Create X extended from a phase 1 study that we had funded through the National Institutes of Health Rapid Acceleration of Diagnostics for Underserved Populations. And we applied for funding to essentially extend and optimize that first study into what you're hearing about today. Okay, next slide. So in the phase 1 study, we convened a 22-member community and scientific advisory board. This included individuals from the community, and most importantly, including those who access services from our partnering federally qualified healthcare center, as well as leadership and administrative staff and providers from that FQHC. We also included some public health researchers and experts as part of that CSAB. This CSAB was led by our incredible community partner, the Global Action Research Center. I think I might have seen the president of the Global ARC on the call here, Paul Watson, on the call. The Global ARC is a nonprofit social change organization with deep respect from our local San Diego community and with expertise in convening community engagement meetings and activities. So they facilitated our community and scientific advisory board and led us through a process called appreciative inquiry to help us identify which strategies were working and which and not, to make course corrections throughout our project. Prior to us launching our Co-Create X project, I'm getting ahead of myself. I'll talk about how we engaged our CSAB to help us with our strategy selection in just a moment. Just as a snapshot of what we did in our first iteration of the project, we implemented a walk-up, no-cost COVID-19 testing site at the main clinic of the FQHC. And that resulted in over 24,000 tests being performed with over 13,000 unique participants in 2 years. So a lot of individuals were served through our first attempt to address those COVID-19 inequities. So we identified a number of, again, challenges and kind of optimization opportunities. So with our CSAB, we engaged in a process called implementation mapping, which allowed us to prioritize and select an implementation strategy package, as JD described, that we thought was going to be the most effective in terms of feasibility and longer term sustainment. And so our CSAB helped us prioritize these 3 implementation strategies. Continuing the walk-up no-cost testing approach. And then the 2 additional new strategies were Promotora's facilitated testing and preventive care counseling to not only help individuals access testing, but also to address other recommended preventive care screening and interventions that could be of benefit to them. And then the third strategy that we selected with our CSAB were vending machines that we named Vendikit, and these dispensed no-cost self-testing COVID kits. And now we've actually expanded those vending machines to include other test kits to assess other health conditions. Okay, next slide. So the 2 aims of our Co-Create X project were twofold. The first was to refine our testing strategies and a related set of outcome metrics for COVID-19 testing. And then our second aim was to then implement and evaluate the impact of those testing strategies among underserved Latino communities in Central and South San Diego, served by our partnering federally qualified health center. Okay, next slide. So these are the characteristics of the 4 clinics who agreed to participate. You can see that 2 of the clinics served a higher patient volume than the other 2. And so we were intentionally wanting to choose a kind of representative diversity of clinics across the network of clinics that the FQHC has. So we worked very closely with our FQHC leadership partners to select these clinics. You can also see that there's a bit of diversity as well in terms of race and ethnicity of patients and preferred language. So for example, Clinic 1, 70% of patients preferred Spanish, whereas for Clinic 3, only 36% preferred Spanish. And I believe that might have been the clinic that another important language for their patient community was Arabic. So we did have to include Arabic translations into our package. I'll also just note that we were interested in, again, addressing kind of the whole person as well. And so we wanted to understand if there were opportunities to intervene on preventive health services. And you can see that there is some variability, but also opportunity to improve preventive healthcare services like blood pressure screening, A1C screening, flu shots, and so forth. Okay, next slide. And then I think this is the last slide I'll share with you. These are the, just to kind of bring to life the project, these are the clinics where we implemented our testing strategies. And these are pictures of the vendor kits. Each clinic participated in a design, I think it was a bit of a healthy, friendly competition and collaboration to select images that represented their clinic and local community. So a lot of beautiful, bright colors, and local artists helped us make these vending machines just pieces of art. So we wanted to share those with you. Okay, back to you, Borsika.
Thank you so much. Hello, everyone. I am going to talk a little bit more about design and the data that we have collected so far, the analysis. And I'm just going to say that we are in the early stages of the analysis. We have done some work in cleaning the data and having a lot of brainstorming with JD, thinking through how the analysis will play out. We had some plans, but of course, as I will show, the plans go wild when you are out in the real world. And so this is what you are seeing now from our protocol paper. If you are interested in seeing one other type of visual of showing this design, the ideal design that we planned to have very nicely equally distributed rollouts. You know, the data collection is also very evenly distributed across the 4 sites. And then you can see how the different rollouts are preceded by optimization activities, which are based on these little symbols indicating data collection after the first rollout and interpretation of that data. So we use data, different types of data, to inform those optimization steps. And then we made those changes. We also made changes to accommodate the uniqueness of the clinics. So that's kind of one of the tricky parts, that we did not only optimize based on what we learned from one clinic to another, but we also acknowledged that each clinic had some uniqueness, and the changes were made to also accommodate those. And JD can comment on this, how this is messing up the traditionally perceived way that ROIO should be done. So moving on, now I'm going to show you a less perfect version of the design, which ended up what happened on the ground. You can see, you know, these are not exactly the same colors, but you can see that this is not as nicely evenly distributed. Data collection points have been shifting a little bit depending on how quickly we were able to conduct the interviews. And we had to do some pauses where the machines were not delivered on time, or they broke down and we couldn't deliver tests. So we had to account for those. We also changed how frequently we are on site at different places, because we had to accommodate the staffing for our project, and the fact that now we have a CDC funded follow-up study, and that had to start. And these added tests that Nicole mentioned were coming from that new study. So lots of real world challenges in terms of doing things exactly the right way. And what we did, we have actually, this is the current version, but we have about 5 different iterations of the design. We made sure to always map those, and the changes are represented. So we know what was happening at each month. And even though we are not doing exactly what we were supposed to, we are documenting what we were doing on the ground. Now it's up to JD to figure out how to solve this mystery, but we have been working very closely with him on this. JD also mentioned, when he talked about the design and what is important, to identify key measures of success that will guide optimization. we used an implementation science framework, which actually could be incorporated into the um, implementation research logic model that JD mentioned. We did not do it for this study, but we have done it in other studies. And as you can see, this includes contextual domains, which we measured using a PRISM barriers inventory before enrollment in each site. And then also specific outcomes, the REAIM outcomes. And some of you might be familiar with the REAIM framework, talks about reach, effectiveness, adoption, implementation, maintenance. Perfect ways of thinking about, are we doing well? What do we need to optimize? And so these measures were also collected. And just as a very brief snapshot, I don't want to get into the details. These are some things that we looked at in terms of the different REAIM domains. One of the things I will highlight, you can see some effectiveness measures here. What we ended up really focusing on is the actual access to COVID-19 tests. We really wanted to understand who accessed these, when, etc. And I will show you a little bit of data. We also were interested in equitable access. And what we couldn't really capture well, but we were hoping is, are we giving the right person the right test at the right time? And so we could have a whole discussion about, how do you measure all of these very complex outcomes and think about them in real world studies. Some preliminary results. I will say that again, we are still doing another round of verification of the data, but based on this, you can see that we enrolled 6,621 individuals and 2,900-ish completed actual surveys. So we have a little bit more information about them, not just the fact that they accessed the machines. We did the PRISM assessment, which I mentioned, with 151 individuals, and they were from different groups. So we had the clinic partners, we had the on-the-ground staff, and we had some community advisory board community members complete these. We had 60 interviews as well to collect data. These were a mix of community participants, promotoras at the clinic, and also frontline clinic staff. And then periodic reflections, as you can see. And so you can also see that we differentiate across the 4 clinics, the timing of the rollout, how many people participated in each site, and then return participants. So some people might have come multiple times, the mean age and gender distribution of these participants, and just some additional considerations, contextual considerations for each clinic. And I'm happy to come back to this slide if there are questions during our Q&A session, but I will move on because I want to just quickly show you one thing that was really interesting to us. The reason why we wanted to use vending machines is because we assumed that the on-site distribution of tests is limited in that people are working, they are in school, etc. So they might not be accessing kits as readily. So this is showing our preliminary information about the distribution times. You can see that about 60% of the tests were distributed outside of on-site clinical hours so basically 8 a.m. or before 8 a.m. or after 5 p.m. And a little bit more detail here. And here I have to rely on some write-up we created because it's a little bit complicated, but this is basically showing the distribution of times when the kits were retrieved from the vending machine using a 24-hour distribution. Each site is color-coded, and the bars represent the proportion of kits retrieved during that hour of the day, and the line represents the average times. You can see that for all the sites between 9 and 11 a.m. is the time that the vending machine is used the most, with a second increase from 1 to 5. And while all the sites have similar patterns, Chula Vista, which is green, has some retrievals a little later than the other sites, from 7 to 8 p.m. And El Cajon, which is our blue line here, has a pretty significant drop-off right around noon. So that's another way that we are looking at distribution times and how we will think about strategies in the future. To summarize this very briefly, we are in an early stage of analysis, but we were very successfully distributed around 6,000 COVID-19 rapid antigen tests. We installed 4 venting machines, which I say with great pride because it's not a straightforward process. And even though it sounded very simple, we actually spent a lot of energy thinking through with our partners how to put these machines into place. And then there are technical challenges, of course, as I mentioned, which is providing 24-hour access for clinics. The patient participants were provided preventative care reminders as well, which is something Nicole mentioned. We wanted to do kind of a whole patient view. And as a result of that, the promoter has facilitated 849 referrals for these patients for vaccinations, cancer screening, and primary care appointments. So more to come, but we'll highlight that we really endorse our adaptations. That's why, the ROIO design was very appealing to us because we knew from our prior work that things change all the time and optimizations need to happen. And we have a very comprehensive system to document adaptations. We just published a paper, we didn't put it on this slide, by Reyes and colleagues, showing our adaptations from the previous study. And from this study, we actually have adaptation papers submitted for publication. Here you can see the distribution of the adaptations from this is the Co-Create study, the Co-Create X predecessor, and then the Co-Create X adaptations are under review, hopefully will be published. So that is another data source we can use in the analysis. I will now stop sharing, and again, we will answer any questions, but I will hand it over to Sylvanna, I think, for their presentation. Let me stop sharing and look forward to discussing this more.
All right, thank you so much for having us. I'm really excited to be part of this workshop to tell you about the application of a ROIO design to support suicide prevention in schools serving families of color. This is a project that was funded by NIMH as part of a R34 feasibility trial led by Dr. Anna Lau in partnership with school districts in the greater LA area. I think we can move, thank you. So as some people in the audience may know, as of nearly 10 years ago in California and in many states now, schools have been required to respond to any student expressing suicidal ideation. And this is a really vulnerable moment when this happens for students because often in schools, this is the first time that they talk to an adult about experiencing suicidal thoughts or engaging in suicidal behaviors. And similarly, parents don't know about it. So they're often caught by surprise. And schools have this really big task of informing and intervening with students. Yeah, we can move on. Thank you. So our work in partnership with schools has shown a lot of opportunities for improvement with the current approach happening in schools. And I'll tell you about that in the next slide. But our work has really highlighted racial disparities in who ends up getting linked to care after a suicide risk assessment. And in our qualitative work that we've done, our research team has heard about issues suggesting quality improvements, both from the side of the families and also hearing about issues reported by school staff. So in terms of issues that we've heard from students and parents, we often hear them saying that the current approach in schools feels pretty punitive and not a collaborative process. So for example, what we've heard stories about schools trying to call crisis response teams, but they're so backed up that they'll have to rely on police to do transports to hospitals because they think that the student needs further evaluation to see if they'll need to be hospitalized or enrolled in a higher level of care. And so as part of the required protocol for police to be able to do these transports in police cars, students end up needing to have their hands zip tied behind their back. And you can see there's a lot of issues like this, and you can see that for any family, but especially for families of color, there's a lot of equity issues that come up in just thinking about what does it mean to have police involved in a suicide risk assessment or intervention, and the meaning of what does it mean when a student looks like or feels like they're almost getting arrested because they're suicidal. We also heard from parents that they felt excluded and in the decision-making process, and particularly this experience of being transported and hospitalized, we know can be fairly traumatic, especially when practices feel fairly exclusionary. So, we also heard issues from the school staff side. This is a really stressful experience for them as well. A lot of school staff have pretty minimal experience with mental health or training in suicide risk assessment. And so understandably, a lot of providers experience ambivalence about being placed in this role of having to determine who's safe to go home. And so we heard from them a lot of issues and concern in seeing that kids were not getting connected to care. And so can you forward to the next? Thank you. So this really seemed to us to present an opportunity to implement a trauma-informed suicide prevention intervention called Safety A. And I'll tell you, I won't be able to tell you a lot about Safety A. We can move to the next slide. Other than to say that it's a single session, family-based intervention that has been shown to enhance linkage to care. So this was trialed among youth who presented to an emergency department after a suicide attempt. And there's 4 main tasks in Safety A. So you are assessing for suicide risk, you're building hope for the future, you're fostering connections with a protective adult, and the goal is to develop a plan for safety. And the next slide, the reason why we chose Safety A is because some of our follow-up work following the Safety A trial has shown that Safety A can be especially effective for youth of color. So here you can see we did some follow-up analysis and showed that the effects in terms of enhancing linkage to care were really concentrated among youth of color, whereas for white youth, regardless of what condition they were in, because their usual care tends to be fairly high quality, most white youth were getting connected to care anyway. And more specifically, why we thought Safety A probably worked, if we can advance, thank you. One of the essential components to Safety A is this idea of fostering trust. So we know that risk assessments in general are a really tough moment for the person in the patient or client role. It's really easy for people to feel stripped of their autonomy. This can be a really scary and traumatizing experience because your hands and your future and sort of the next steps are in the hands of a clinician or school staff. And so Safety A thinks really deeply about how you can create moments within a risk assessment that bolster voice and choice, and really try to promote trust and autonomy while also maintaining safety. This is a really foundational principle in the intervention, which we can advance to the next one. Thanks, Anna. Which ultimately helps you through the intervention to develop a plan for safety that has the potential to reduce unnecessary deployment of emergency services, which, like I said, we know can be traumatic. And so some work, I'll say, with schools that our team has done, through that work, we know that there are some practices that schools are engaging in that are not totally consistent with these Safety A principles. So for example, we know that often when students are suicidal in schools, they have their backpacks taken away from them and their lockers are searched. And this can be feel fairly violating of autonomy. And similarly, like I've mentioned, schools are fairly quick to call crisis mobile response teams for further evaluation, even when it's not necessarily indicated clinically. And so we saw an opportunity in schools to also de-implement practices to try to align with trauma-informed principles. And so we wanted in our trial to think about an implementation plan that can help schools absorb this intervention in a meaningful and sustainable way. So I'll give a really quick overview of the 3 aims of this R34. So in the first aim, we wanted to use human-centered design to think about adaptations or implementation strategies we might need to develop in order to help schools that serve low-income racial ethnic minority families to be able to absorb Safety A. And then in our second aim, we went through a case series to be able to refine this approach. And we use iterative prototyping based on a single district. And then in our third aim, which is the feasibility trial, we actually initially thought that this aim was going to be about just tailoring our implementation strategies to specific districts because there was a lot of diversity across the workforce in different districts. So some districts had people that were trained, specialty trained in mental health, and some people relied on a workforce that didn't have that specialty training. But when we started doing the work, we realized that there were differences in the workforce across districts. But in terms of advancing equity for minoritized communities, we actually saw a lot of overlap. So we saw that our lessons in terms of the implementation strategies that we developed, these lessons carried forward from one district to the next. And so our implementation strategies for each district often built off of each other, and we focused on optimizing our strategies to be responsive to each context. And so I'll turn it over to Anna.
Thanks so much, Sylvanna, for setting up the context for this study. So this was a really heavy lift and a big ask for schools, a really big change from usual care, and a lot of complexity in the intervention, which wasn't developed for schools, right? It was developed to be used and deployed in the emergency departments with, healthcare professionals. So aim one of the study was really, like Sylvanna said, to use human-centered design to adapt safety for schools serving predominantly low-income immigrant communities. So we used, kind of the traditional qualitative approaches to, really partner with stakeholders and schools, personnel, and school district leadership to really understand how this intervention may be made feasible in school contexts. So we used theater testing initially, a lot of individual interviews with youth and caregivers and focus groups to really vet our initial ideas about both EBI adaptations, as well as a bundle of implementation strategies that would help school personnel be able to deliver safety A. And then we also had an opportunity to try out that initial set of strategies and the adapted intervention in that case series in AIM 2. And just to talk a little bit about some themes that emerged in our stakeholder engaged work in AIM 1. We certainly heard a lot about cultural factors that we needed to address related to how, patterns of communication and coping with emotional distress that maybe really need close attention in terms of cultural differences in the delivery of the intervention itself, and that generated a number of EBI adaptations that we carried forward into the feasibility trial. But in terms of implementation strategies, a couple of driving themes that really helped us organize our thinking about the types of implementation strategies we needed to have on board. We, of course, heard a lot about resource constraints in schools. Sylvanna already talked about the wide variation in the school workforce that was tapped to carry out suicide risk assessments, and we needed our implementation strategies to be able to accommodate that variation in workforce preparation and skill set. And then another really big issue we heard about over and over again, and Sylvanna mentioned this in terms of system involvement and the fragmented system of care that we have serving youth with mental health concerns. And as for communities of color and low-income minoritized communities, we heard a lot from our stakeholders about sort of the legacy of long history of system over-involvement with communities of colors, which really set up encounters that were sort of characterized by learned or what we might call earned mistrust with systems of care serving youth and family and caregiver experiences with coercive systems. And this is definitely comes up both in specialty mental health care, but also in emergency services, definitely child protective services and law enforcement that gets involved in these high acuity encounters. So we knew that that was a major equity issue for us that we needed to address as we brought this intervention into schools. So some of the intervention adaptations that we developed going into these communities really were informed by that AIM 1 qualitative research. So we added some specific attention to helping immigrant families discuss emotionality, coping with emotional distress, and centering family experiences in terms of the ways that they are accustomed to and comfortable supporting their youth in crisis. and really doing a lot of psychoeducation with providers about this and framing the intervention in the context of accommodating this variation in how families support youth. We also started with our initial best informed set of implementation strategies, and we really, again, started from the vantage point that we would really need to tailor our implementation strategies to local educational agency policies, who their workforce was, how well prepared they were, and what was the system of that we were working within in terms of the local mental health services capacity and crisis resources. So we started out with developing implementation plans with our district leaders, and our package of strategies looked something like this. And then in our actual feasibility trial, we have really started to think about and look at what we did through the context of a ROIO design. So we trained school providers in 4 districts. This was really a wild and crazy study to do this in a R34. Year 1 was Ames 1 and 2, and years 2 and 3 was this really rapid rollout across 4 school districts. Each school district really having their implementation, active implementation training consultation period in 1 semester, so fall semester and winter semester across these 2 academic years, and we covered 4 districts. And you can see just from this slide, the districts that we were in, wide variation in the number of folks who we trained in Safety A and their background and disciplines. Some districts really focused on a highly specialized workforce that was centralized at the district and dispatched sort of more senior mental health service providers out to their school sites to meet the needs of youth, whereas other folks were using sort of all hands on deck at every school site, and that's how they approached serving their youth who presented with suicidal thoughts and behaviors. So overall, we trained 222 school-based providers who were based in 90 schools across these 4 public school districts. And I think one thing that we really wanted to highlight about ROIO and its utility in thinking about equity and thinking about building out implementation strategies that are going to advance equity in various health care providing settings was thinking about moving across units or clusters that occupy, different social contexts really is, we feel like, very helpful in the end. Folks who work in schools know that you've been in one school, you've kind of been in one school, and they're also unique in terms of their relationships with the community served, and this sort of royal lens freeing us to learn from one context to the next and carry forward lessons and implementation was really, really helpful. And each school district that we worked with really, had its own history with their community, which was transactional, and really let us learn about what some of the barriers to equity were, especially in this context of intersystem coordination. And we'll hope to illustrate that with the kinds of implementation strategies and the ways we try to optimize as we learned lessons from one district to the next. So in our work, our first district, and I don't know if you can see our cluster, my cursor, but in our first district, that was a long-time academic community partnership with a district that was serving Asian American and Latine families in the San Gabriel Valley. District 2, farther east in the county, served primarily low-income Latine families more adjacent to the Inland Empire. And District 3, also a longtime community partner, but served a much more diverse community that straddled a more affluent beach community with more middle class white families, as well as a lower income Latine and Vietnamese community in northern Orange County. And then our last district was close to central LA, again, serving a almost exclusively low income Latine community. Okay. So applying Arroyo design really allowed us to continue to learn and optimize our strategies beyond the initial bundle of strategies that we developed in partnership with stakeholders from across many districts who informed that initial plan for implementation. And all along the way, we were really focused on strategies that would help us address barriers to implementation that we saw really stemming from this history of system over-involvement with communities of color and issues of mistrust that arose at multiple levels of interaction. And our goal was really to bolster trust and advance equity goals. So, an initial optimization that we made was really to address provider misgivings about trying out Safety A with quote unquote high risk students. And really, they had a strong preference to use brief screeners and quickly call in emergency services. We already had leadership strategies on board, but this was really a matter of intensifying, I would say, in JD's terms, leadership messaging and support, really communicating the rationale behind the mandates for change continuously, and having leaders join us in our consultation calls. And tailoring messaging across school sites about the district's commitment to this work. We also developed a lot of new education materials for providers to give them more context for how Safety A could promote safety and de-escalate youth and really prevent the need for emergency services in many cases, but that the behavioral risk assessment needed to be done before ascertaining who actually was at high risk and needed that care. Another barrier that we encountered in another district was providers showing low readiness, specifically for collaborating with caregivers. Many providers were very comfortable working with students, and then felt really unprepared for the work with caregivers. Many of them would say, we're not family therapists, for example. And so we did feel like we could help bolster with some additional skills training here as a new implementation strategy to develop educational materials and skills training on motivational enhancement strategies that were really essential as a foundation to collaborate with caregivers in these moments of crisis. We also, in terms of ERIC type strategy, made our training more dynamic and provided recognition to early adopters and folks who were making change in their practice in this direction. In another district, we encountered that providers felt that actually involving and leaning on these additional care systems, such as Child Protective Services, was a useful approach with hard to engage caregivers. So these might be caregivers who, were really reluctant to accept referrals to specialty mental health services, for example, who uh, you know, uh, were difficult to engage. And we spent a lot of time in consultation, again, then applying motivational enhancement strategies in consultation sessions. We also leverage sort of team-based processes to amplify the voices of providers and school site teams who were themselves minoritized and had some lived experience with coercive systems, actually in making consultation more dynamic and a place to really hash out some of these really difficult issues. And finally, in another district, we again observed uneven and low overall provider buy-in for adopting SAFE-DA initially, and actually low trust with the implementation team. And this was in a context of a rescue strategy where this district, we didn't have the typical timeline to do implementation planning. They were actually a replacement district for a district that had turnover at the superintendent level and a big crisis at the district level. So we found ourselves onboarding a new district in this last cluster. And so our strategy to encounter this barrier was to really leverage our other strong community partnerships and building trust with the new district through practices of network weaving. And we brought in our partners from prior school districts who had adopted SAFE-DA to discuss their journey and process in adoption and implementation. And this was actually a strategy that was requested by this fourth district. They really wanted to hear not from researchers, but from their school professional peers in thinking through how this could actually be done. So overall, these optimizations really centered trust and collaboration to advance equity. These barriers to trust emerged at different levels of interactions between leaders and providers, between the research team and providers, between providers and families in these districts that were all situated within this outer context of interconnected systems of care and histories of coercion with communities of color. Um, and we really recognized that there was a great need and opportunity for these new optimizations. And in our case, JD talked about the need to have a protocolized decisions for optimization. And for us, our driving force was really to lean deeply into our community partnerships and to really follow the lead of what our community partners were asking for. And these conversations emerged in real time in our training and consultation process, in communications with individual providers and leaders, both formal leaders of the district, such as superintendents and directors, as well as key opinion leaders among the providers we were training. And in every case that we're talking about here, the refinements in the strategies were applied forward to subsequent districts in this process of what we really felt like was optimization. And in terms of tracking and measuring these adaptations and implementations, they're primarily qualitatively documented in our consultation recordings, in our leadership meeting notes, in team periodic reflections. And our implementation team weekly debrief meetings. And then we also have them kind of codified in our artifacts from our training materials that we developed along the way. So we really feel like this approach to optimization is consistent with our long-standing commitment to community partnership. And a lot of this work, comes on the heels of a really long history of trying to meet school districts' needs and really kind of centering listening to what's working for them and what's not. And I'll just want to acknowledge our funders and everyone that worked on this trial. And I'll stop sharing. I think at this point, I guess I'm to invite all of our panelists to come back on camera. And I think we have time now for some general Q&A before transitioning to maybe a more informal consultation period. So I'm looking to see, I'm not sure if you have been tracking any specific questions that have come through the chat that we want to address, or any prior questions that were submitted before the webinar.
I think
Lou,
Borsika. Oh,
go
Jay?
ahead. Yeah. I was going to say, Luann's question was, I think, a really good one about individually tailoring strategies to clinics within clusters versus, I think, the examples that were shared by these two projects were sort of there was only basically one unit for each of the clusters. And so it naturally is tailored to site if you were applying that kind of similar logic to the project examples that I gave, where there's 8 to 10 clinics within a cluster, um, it would probably cause some issues if you were individually tailoring to all 8 or 10 within the cluster and then doing that, because the idea really with most of the analyses is that you're comparing cluster to cluster. You're not really comparing clinic within cluster to clinic within other cluster. It's not that it couldn't be done. I think power would be challenging, and then interpretation of what caused the effect would be a problem. So the thing that I mentioned in the chat is if you really approach this as testing one strategy, and the strategy is individually tailoring to context, and you wanted to just show like, does this tailoring into context get better over time? You could absolutely answer that question. It would just be a quite different I guess framing of the use of the ROIO. It may be a little bit more limited, but would certainly be possible.
And JD, to that point, I wanted to ask you to say a little bit more about what happens if we optimize in the next cluster, but then of course we continue delivering the intervention in the previous cluster, and now we want to do better there, so we are going to apply these improvements there as well.
Yeah, that's a good question. So that does raise some challenges too, in that, if you're messing with cluster one and you've made the same changes to cluster two, your comparison data becomes very similar. So what you might end up being able to do is compare within that cluster, did you get better? But then your between cluster comparisons might be a little bit more difficult, both that the changes might be so minor that you wouldn't be able to detect an effect, even if it did exist. But the other thing is it's just, you're basically then doing the same exposure for the remainder of that initial cluster that cluster two gets. So that data almost becomes like combined, more or less, but not really, because that first cluster actually did something different for a bit before you messed with it. So yeah, it's a tricky piece. And that question does come up quite a bit. What we have sort of done in our projects, and I'll let you say what you did too, but what we've done is really say, if this is an absolutely critical thing, that if it doesn't get changed, like, this is going to fail, we've made the change, but we've also tried to not go all the way to, okay, let's use the cluster two version for cluster one.
Yeah, I do want to just sort of name that our project, is a feasibility trial. It's a developmental trial. So it's really not, a definitive hybrid effectiveness implementation trial. So in our case, it's just sort of want to name that um, and sort of acknowledge that most people who do community engaged research and implementation research, they're not going to not withhold, right? What is needed to make something work and to support a a setting that's implementing. So that's kind of just the reality of it. And so I just want to kind of hold that tension when you're and particularly in a developmental trial, we really felt like, we need to do right by our community partners. I think when it comes to a definitive hybrid trial, then that's where you're compromising the internal validity of a trial, right? When you're kind of messing with the concurrent unit. So I just want to sort of say that, ours wasn't truly designed to be analyzed as a ROIO trial. And so that gave us a lot of latitude. But I would really love to hear from folks who, are caught in that, quandary. How can you kind of not optimize on the go and do what's right by your community partners? It's a difficult thing to say.
I think that point, that sort of, I'm going to call it a moral obligation, to do right by your community partners, really underscores the need to have a really good implementation strategy package for cluster one. So the thing you're really trying to avoid, and this goes into the moral thing, but also just some of the assumptions about the study, is you really don't want that first cluster to fail. Because in this design, you're not going to change it a ton, and that means they're going to get an inferior strategy throughout. So it really does underscore, like, you need to be really, really thoughtful about that first strategy being effective. And if it's really affected, that is actually not a problem because you can start to do those dismantling pieces and try to reduce the cost, make it more feasible. It might change a little bit the nature of the question you're answering, but I mean, nobody's gonna complain that your initial strategy was awesome, right? Like that's only a good thing for our kind of work.
I love that. So what we are going to do, Nicole and I will help a little bit with the coordination of the questions here. We have some questions that we received prior to this meeting, and we will bring in some of those. But I want to call everyone's attention to the chat. Please put in your new questions. This is the time to ask those, and we will try to get them in immediately. So the chat is a great way to communicate with us. And with that, I will ask one more question, and then I will ask Nicole to bring in something from the previous registered ones. This is not in the chat. You answered a number of questions in the chat, JD. One of the things that came up in our discussions is, how big the change needs to be considered an optimization. How do you think about that? We make adaptations all the time. Our study has a very, again, as I mentioned, systematic way of tracking all kinds of adaptations, small and big. How do you decide which one of those should be accounted for in this optimization piece, and which one are just ones that will happen naturally, regardless whether we are doing ROIO or not?
I think this is one of the trickiest things, honestly, about this, is there is a fine line between did we do enough that it's optimized, and that it's enough of an iterative improvement that you actually reasonably could hypothesize that you've done something to make it better. With there's a tipping point of you changed it so much this is no longer like resembles the original strategy, right? So that's again going back to that really protecting yourself against failure, because if you're wholesale getting rid of a strategy or wholesale getting rid of your bundle, it's just like, oh man, we totally screwed that up somehow. Then you're kind of starting over, right? Then cluster one basically disappears as being relevant data. So there is there are decisions that'll have to be made. And I'm curious if either of your studies actually encountered this of saying like, well, we could make these 4 changes, but actually let's only make 2 or 3 and save the other ones for another iteration in a different cluster if necessary. And we've had those conversations in our studies too of should we actually do all of these things, or should we do just a few of them, get the data, then optimize further, thinking that, oh, this is probably where we're going if the data, is consistently showing that this is the problem.
I can maybe share for our project. I would say that many of the optimizations, and Borsika, I'll be curious what you think, were in many ways responsive to kind of changing landscape, the changing landscape of either the pandemic or our kind of clinic's needs and patient population. So in some ways, it was, yes, informed by kind of data we were collecting, and also a lot of kind of field experience from our research team who were kind of boots on the ground. And so unfortunately, many of kind of the optimizations we made were sort of critical for any of the sites and for kind of a next site. So I would say many of the optimizations were almost, responsive optimizations.
Yeah, and I think that is very much on spot, Nicole, that we came up with a pretty strong bundle, as you suggested, JD. I feel pretty proud of it because we used input from the different sites and we worked with these partners for years. So the idea of the bundle was strong. What changed was more about how we put this bundle into place as things change over time, or as we move into a new clinic that is a little bit different from the previous. And so it is a great conundrum as well that in our case, it was more optimization to the context, both in terms of over time and geographically, not so much changing the main components of the bundle and what does that mean in terms of ROIO. So not sure how to think about that, but that is certainly where we went. So we are still using the same core components. The core functions were the same. We might have made small changes to the forms. So Nicole, would you like to bring in one question from our previous or pre-session questions? I'm also scouting through the current questions in the chat, but again, I will make one more call out. Please put your questions in there. Any question is okay. We have about 5 more minutes with the larger group. And then those who are interested in a little bit smaller consultation setting, they are welcome to stay on through 10 o'clock Pacific time.
Great. Well, I'll bring up a question that's kind of a bigger methodological, maybe philosophical question. What does this approach, the ROIO approach, add beyond other designs? How do these results tie into economic evaluations, as an example? JD, I think you gave a nice example from one of your studies, but maybe if you can lead us in this, kind of thinking through added value of the ROIO.
Yeah, I think you can apply typical time-driven activity-based strategy costing approaches to this. That's what we were doing that underlies those ICER analyses for doing cost effectiveness. So that's certainly a place that dovetails nicely. Also in the chat, there was a question about strategy tracking, and I think that it just gets underscored in this type of a design to really, really be, detailed, but also really careful about exactly tracking what you do to change in between, and that it was done with fidelity, right? It was done as intended in each cluster. Certainly, those are slightly different things, of course, documenting what you plan to do versus what really actually happens. I might take your question in a different direction too, though, of what is different about this design than other adaptive trial designs. So if you think about the big class of adaptive designs, things like smart trials are part of it, are part of that. So just to contrast with a smart, because folks probably are a little bit familiar with that, with a smart, you have to pre-specify what your other randomization conditions will be. The ROIO allows you to do it in a data-driven method, a data-driven approach. So you might have ideas about where you're going, but you don't pre-specify, like in cluster 2, I'm going to change this, and that becomes my new strategy package. If you have those ideas and you know that's what you're going to do, it's just not a ROIO. Right. That's sort of what differentiates it from a 3-arm study or a 4-arm study or a factorial or some other kind of adaptive design. So the ability to really follow the data in that way, it almost like more similarly lines up with like the dynamic adaptation process, where you're doing data-driven optimization. Typically the DAP is like within cluster or within a site, like you're trying to improve over time rather than successive clusters. So that's the other piece that the ROIO adds, is when you do it by cluster, you can do cluster-based comparisons that give you a much more robust test. One of the downsides of doing with insight change is that it ends up basically being like a quality improvement type approach or type, kind of framing, which isn't as conducive to rigorous, testing, and may not be viewed as positively by reviewers too. So this really adds that additional quantitative rigor component to an optimization or an adaptive design.
And JD, I'm just thinking now as you are describing this, whether when you are finishing your paper and perhaps you already have this as a component about ROIO, having this guidance about almost like a decision tree of when ROIO is appropriate, because I wonder, at least for our study, did we choose the right design and are we using it the proper way? And of course, in these early stages, everything can go. But I think having some decision tree about when would you want to use ROIO, it sounds like there are some different uses, not just one, but there are certain uses that are not appropriate.
Yeah, for sure. There's definitely some contraindications. I do really like the way that you both presented your projects as being somewhat developmental pilot. I do think that's a really appropriate use of this design of, the one that I presented was really more of definitive, like, hey, we have a really good idea. We have evidence that the strategy is going to work. We're just going to try to make it better. Right. That's sort of the bread and butter, the basic of a ROIO. But if it's more developmental, it's like, hey, we have some ideas, but this is the study that's going to help us get the data to actually propose, here's what we should move forward with. So, very different kinds of aims, but I do think that that more like pilot formative it's a great use of this type of design. I think for the reasons that Anna mentioned too, that it allows you to really kind of go crazy a little bit if you need to. right, in response to what's happening in your community. And I say go crazy, just meaning like don't be constrained by protocol fidelity and some of the things that we have to do for a larger trial.
One thing that I think folks have mentioned is kind of how heterogeneous are the units in the rollout is a really big deal. And if you have like a huge healthcare organization and you're developing clusters within that, or like arbitrary clusters within that, that's really different than most times when you're bringing like a novel EBI, to highly heterogeneous healthcare organizations. Um, you know, I can see in the former case, you can keep a really tight ROIO design. You've anticipated, the barriers and facilitators for that overall organization really well, and then you can be kind of maybe more sparing or systematic or withholding of when you bring on an optimization. But in the case, with Nicole, like Nicole and Borsika's 4 sites that were very different in our 4 school districts. They shared a lot of characteristics, but they were embedded in very different histories, had very different histories of relationships with their communities. You don't know what you don't know, right? Before. And so hopefully by the end, you've developed a much more robust, generalizable set of strategies that is going to allow you to meet the needs of a wider range of organizations. So I really see the value there. And also, maybe the opportunity for, you know, more change or like a call for like more optimization and iteration. So I really see those as 2 very different like subclasses of the ROIO, where you're dealing with relatively homogeneous sites versus like you're going to encounter very different inner contexts.
Yeah, really good point. I think, in the 30 cluster example or 30 clinic example that I showed, they're all federally qualified health centers or community health centers, should say. But they come from different organizations. So it's like, you have one that's, Erie Family Health that has 10 locations. Then you have 2 or 3 others that provide a certain number of locations. You cannot have like all Erie clinics be cluster one, right? So you have to actually then do your randomization to mix and match clinics across the clusters so that you have balance. It does make it much more complicated. And I do think the example of having, like community health centers with academically affiliated primary care clinics it would be challenging, right? Because your exposure is probably going to have to be different beyond just the ability to balance across your clusters. Balancing actually would be the easy thing in that. If you had to provide different strategies for each of those different types of sites within cluster, then you've got a different kind of design probably that you would need to do. There is probably an extension of a head-to-head or a 2-arm or 2-group is kind of ROIO, but I haven't thought through that. So stay tuned. Maybe that's a future paper or some really bad application that I put in for fun.
Love that. So as we are continuing our discussion, we will just naturally flow into this more consultation format, which will not change anything in reality, other than I will encourage everyone who stays on to unmute and ask your questions live. I think that's feasible. I asked about it. So please go ahead and stay on if you would like to communicate with us, and we perhaps could take down the spotlighting so people can be seen.